Oh. What the fuck? Okay, we start in 20 minutes. Hello, how you doing?
Hello, John. How are you?
Good, good. I wasn't sure whether this internet connection would work, but it's pretty good here in Maui.
Oh, it's very nice. We can hear you very well.
Very good.
Just let me 5 minutes and we
Yeah,
will
sure.
adjust
Yeah, I'll
Dr.
be here.
Ümit's laptop
Okay.
too, and I will adjust the
Yeah,
lighting here.
okay.
Abi tamam. Girildi. Toplantı açık. Toplantı açık. Bizim evimize 10 dakikada Eryaman'da bir şubeleri var.
Ha, doğru.
8-10 tane şubeleri var.
Orası iyi miymiş?
İyiymiş. İyiymiş. Bir de tanıdıklar da var. Bunların hastasıyla iyi olabileceğini düşünüyorum. Bir şey var, anladım ben. Abi Rolex.
Ne kadar istiyoruz?
Abi 200 bin lira. Benim fiyat. Çünkü Nazım Hoca'nın iyi gördüğü için 200 bin lira.
Sonra
Yani o da bana iyi geldi. Hiçbir şey değil. Aylık 15-16 bin lira. Bir şey değil. Diye düşünüyorum abi. Belki İngilizcesinde falan hani bir şey eksik kalmasını istemiyorum. Şimdiden beri bir sormuşum da hasar görmüşüm gibi hissetmeye başlıyorum iyice. Evet yani ilkokul artık yeterince oldu.
gerek yok zaten. Bunu yeter.
Yani fazla tutmadım yani. O yüzden
Sadece bir şey mi? Doğru mu? Çok şanslı. Bir karede bir tane 60 yıl daha yaşamış. Böyle. Bir 6 sene önce kadar ameliyatlar 60 yıl. Yani bilmiyorum. Şimdi şeyler doğru. Belki doğru. İnsanlar ama ben 70'li yaşlarında aynen evet, bunlar böyle kazandım. Ben tamamen nasıl olmasın. Bizdeki hocalarımız genel olarak bir ekol var. 45 yaşında bırakan bir ekol var. İşte 55-60 yaş. Yani bu 55-60'lar sonra biz ekolden bir şey seviyorlar. Yeter bir biraz şey geçiyor. Böyle bir şey. Acil derecesi 45. Zaten bir şey kullanmak. 5 yaşında bırakıyorlar.
So, sir, I hear you are on vacation.
Yeah, not really. I came here to see my brother and to see if I want to move here for a while.
Oh, okay.
I'm not sure. Miami, I know it. I know how everything, but here I'm kind of lost.
Yes. In which state are you?
I'm in Maui, Hawaii.
In Hawaii, I
Yeah,
understand now. Okay,
yeah,
okay.
yeah.
But previously you were in Miami.
Yeah, I usually work in Miami Beach. I'm
Uh-huh.
used to it. When you go to different computers, sometimes it's a little tough.
Yeah.
Yeah,
If you can operate a studio in Hawaii and with good internet connection, then
yeah,
maybe.
yeah, that would be great if that would be the ideal situation.
But what about there was a tremendous fire in Hawaii? So I think the internet cables are.
Yeah, I think they're pretty good. They're just as good as the mainland. Uh, we had a storm here. I don't know. It's working okay now, but it was out for a little bit. But
Okay.
have you ever traveled trying to connect to the internet? It's a little difficult when you're at a hotel or something like that. You got to get used to it. And for
You need to
me,
have an established base. An
yeah,
established base.
yeah, yeah. With my base, I mean, I have the Photoshop. I have the things I can use here. I don't have too much that I
Yeah.
can use, like software and stuff like that. But
It will be hard to carry all your stuff, but being together with family, it's better.
yeah, no, yeah, yeah. No, no, I'm single, so it's not that hard. I don't have any children, so it's not
Mhm.
a big, huge thing.
Oh,
And
of
if I,
course.
I'm with my brother now. He has a little house on his property.
Does your brother have a family or kids?
Yeah, yeah. His kid is grown. He has his wife here, so I'm not a stranger, and I've been here before. Uh, I told you I was close to Greece. I went to Naxos in the Greek
Nexus.
island.
Yes, I know.
Yeah, yeah, it's one of the islands there. I was very close to Greece, and I wanted to try to go over to Ephesus because I like,
Ephesus, yes, in İzmir.
yeah, I like Greek mythology. I like Greek history.
Yes.
And apparently, it has more there than Greece.
Yes, it's actually a bit true. But some part of their history is in Anatolia, some part in the mainland Greece.
Yeah, yeah. It's I went to Naxos and Santorini. That's it. And
Okay.
Athens, of course. You've been to Athens, right?
Yeah, in Athens. I haven't been to Athens, but I want to visit.
Oh man, what if you like museums and history, which I do. I love
Yeah,
Greek,
I like to.
and I was in heaven. Like we spent
Oh,
3 days in Athens, and it wasn't enough for me.
oh, really?
Yeah,
Yeah.
there's so many great museums with original artifacts, statues, the original.
Oh, I really like medieval times history and also PC games and history books. So I should definitely visit Athens one day. It's
Yeah,
in my
yeah,
to-do list.
medieval times. Uh,
Yeah.
I don't know where you'd experience that the best. I'm not sure what city in the.
Medieval and also classical age, I think. The
Yeah,
Hellenistic period.
Spain is a good place for that. Medieval.
Yeah. Yeah. Yeah.
I didn't. Yeah, I love Spain. I love Madrid. Madrid's the
Mhm.
nicest place I've ever been to.
I visited a few places in Europe, but Spain and Athens, I should definitely visit them.
Oh, Spain. Yeah.
Yeah.
You're a practicing neurosurgeon. Or are you
Yeah,
waiting?
I'm a practicing neurosurgeon
Oh,
actually.
okay.
Every day I
Yeah.
have operation cases
Oh,
and I
okay.
work in Ankara University. But I have 1 month of summer holidays.
Now, are you gonna introduce Umit? Oh,
Yes,
okay.
yes, I will.
I'll introduce you, and you give him the proper introduction. Okay.
Of course. We are both working in Ankara University and we are active working neurosurgeons.
Okay. Let me get things straight out here. You're right? Murat's your name, right?
Yeah, my name Murat, surname Zaimoğlu.
Zamoglu. Zamoglu?
Yes, yes,
Zamoglu.
okay.
A practicing neurosurgeon from Ankara or from
Ankara
Istanbul?
University.
Anchor University.
Sir, I will be in here in 2 minutes. I will just check
Yeah,
Dr.
yeah, no
Yu's
problem.
laptop.
We start in 10 minutes.
Yeah, we are in the same office actually. I
Oh,
will just
okay.
check his laptop too.
Okay.
Okay.
Harika.
Ama çok yoğun. Öyle belirli dertli, dikkatli falan olan şeyler değil. Sınav odaklı bir ürün.
Yani %75'i %5 gibi görmüştüm. Diğerleri bir şey gerçekten. %75 bir bu mu?
Sadece eleman değil tabii bütün okulları yapıyor.
Öyle mi?
Evet ama okulları da kalksa bir öğrencileri çok iyi biliyorum.
Bilmiyorum. Çok işin kadın topluluğu bilecek. Evet, saatinde acil kullanımı nasıl almayı?
Yanlış şart.
Ben eskisi gibi düşünmüyorum. Ülkede ne oldu? Saatte oldu. Ankara mesela Reşit'in mesela.
Nerede?
Ege'nin mesela kaç tane öğrencisi var aslında. Ne oldu?
Aile eğitimi.
Acil eğitimi. Çoluğu da baktım da. O çocuklar büyük ihtimalle aileleri oldu. Bizim gibi işte sınıflar kazansı noktalar olsun. Yani onu kazanma ne oldu yani? İşte söylüyorum bunu Birleşikler Hastanesi'nde acil eğitim. Manyaklar da düşünüyorum.
Öyle yaptık. Doktorluk gördük. Belki de göz başka alan demekte faydalı olabilir abi. Göz alımına. Ziyaret mi? Diş hekimliği mi? Yani bu tabii ne kadar çok şeyden ne kadar çok
Yani
hemen arkadaşım var.
o zaman konuşuyor musun diyor. Sen de konuşuyor musun?
Değil.
Doktor çok haklı.
Aslında çok unutmuş ya. Artık çok ve sadece parasıyla rahatlıkla olabiliyor. Yani o.
Ha, özel anlamda diyorsun. Ama özel kısmı bir şey
Evet.
yurt dışına böyle. Yurt dışında adam gidiyor Macaristan'da okuyor. Kağıtları okuyorsun. Çoğunluk kağıtları okuyorsun.
Macaristan'da tıp bitirdim kesinlikle. Ama tıp yapılır mı abi işte o sıkıntı. İnsan marangozu gibi.
Manyak mısın lan? Doktor olur mu? Deli olmak lazım yani.
Hele ki kızım için çok istemem abi. Bedeller büyük yani.
Ben tarihsizliğini düşünmüyorum. Çok uzun süresi düşünmüyorum. Bağlanabiliriz herhalde.
Evet abi. Ben hiç bağlar. Benimki bağlar.
Okay, sir. Dr. Amit is also ready and
Oh, good.
connecting.
Good. You guys in St. You're at that hospital in the background. That's where you're at.
Yes, it's my university, Ankara University.
Oh, okay.
Actually, 1 month before, you advised me to put my university in the background for more professional.
Yeah, it
View.
looks good. Looks good.
Yeah, this picture was your suggestion.
Yeah, it looks good. Yeah, I thought of just putting a background of Maui in here. You can change them easy, as you probably know. Let me see if I can get one here. Maui, here's a picture of Maui.
Yes, your
Yeah,
new
sure.
background.
Yeah, let me pin that. Yeah, it's it's got tremendous beaches. The waves here are very powerful.
I guess so. Yeah, for surfers.
Oh man, the waves are big and they're powerful because I love to body surf. Have you ever body surfed where you go in and catch a wave?
No, I have never tried because I'm
Okay.
afraid of sharks.
Oh, okay. Well, there are a lot of sharks here.
Really?
Yeah, my brother came very close. He came right up to his kayak and tried to and hit it with his tail.
My God, it's
And-
interesting.
and-
I once saw a sea turtle swimming, but it was very big, and I was crazy scared. If I
A
see
sea
a shark,
turtle,
I
they're
don't know what
harmless.
will happen.
They're harmless.
They are harmless, but it followed me while swimming, so
Oh,
I
you're
was
kidding.
scared, very scared,
Yeah.
because I couldn't identify what's that. It's like a big table swimming. If I
Yeah,
see a
no.
shark, I can't imagine.
No, I was in the water and they said, shark, there's a shark. So I went only a 5 foot. They're not big. Not one of the big ones. I saw one. It wasn't too far, but I still didn't want to mess with it, so I just got out.
Of course, of course.
But there are attacks here all the time. It's probably one of the has the most deaths of any place on earth. Australia, South Africa, and have the most deaths to the shark.
Yeah. So
Good.
we will start in a few minutes, in
Yeah.
2 minutes.
Yeah, a few minutes.
Yeah,
Whatever.
we can start in 1 minute.
Okay. Good morning, doctor.
1 minute.
How are you, doctor?
Thank you, sir. Good to see you.
Good to see you. Okay, we're almost ready to start. Just a minute here. Okay. Okay, Murat, you ready?
Yes, sir, I'm ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett, broadcasting from Maui this time. I'm on the road. You can see it in the background. We have the sixth in the series of Evolution of Skill, the Art of Microsurgery with Dr. Umit Eroglu. And I'm going to have Murat Zaimoglu from Ankara University, neurosurgeon. He's going to give the proper neurosurgery introduction. Welcome, Murat.
Hello, Dr. John. It's always a pleasure to be with you. And today I would like to introduce Dr. Ümit Eroğlu, who is working in Ankara University. We are working together there. And today we will speak about anterior skull-base meningiomas with supraorbital approach. Hi, Dr. Ümit.
Hi. How is it going? Good.
If you are ready, we can start the
Yes.
presentation.
Yes. Hello, everyone. I am Dr. Ümit Eroğlu from Ankara University Faculty of Medicine. Today, we will conduct the sixth session of the Microneurosurgery series together with Dr. Bennett. First of all, I would like to thank him for allowing us to share our experience in microneurosurgery. As you know, I have been deeply involved in minimal invasive microneurosurgery for a long time, with extensive experience in supraorbital and other keyhole approaches. As discussed in our previous presentations, there is a preparation process for our patients. We do not administer fluids to our patients, except for lobar hematomas or large interaxial lesions. I perform a lumbar puncture on nearly all patients. This allows us to create extra space between the frontal bone and the cortex. One of the most critical aspects is patient positioning. Head elevation and hyperextension are essential. For olfactory groove meningiomas, a 30-degree condylateral rotation is required. You can see the patient positioning, head elevation and hyperextension are very important for this approach. Eyebrow shaving is not necessary for this approach. The supraorbital notch is palpated and the incision is placed lateral to this notch. Initially, I used both eyebrow lines, but now I find that a single eyebrow line is sufficient. Or the point. However, olfactory groove and tuberculum cella meningiomas are not suitable for beginners. This patient has a frontabasal meningioma, making it a suitable case for a keyhole approach. It is located at a safe distance from major vascular and neural structures. In this approach, drilling the inner table of the frontal bone and the orbital roof is critical. This provides additional space for manipulation. Cortical and frontabasal tumors are relatively safer. In classic meningioma, you can see devascularization and debulking are fundamental principles, which also apply here. Tumor is debulked using CUSA and bipolar. You can see the tumor is quite firm. CUSA is not always effective as I would like, so I remove it piece by piece. This kind of cases are very suitable for the beginners. You can see I remove it piece by piece. CUSA is not effective. After tumor excision, we use an endoscope or exoscope for final inspection. We checked the surgical field.
Dr. Ümit, this is endoscope vision also, combined
Yes.
with microscope, isn't it? Yes.
Yes, it's an exoscope. Here we see a huge olfactory groove meningioma. Preoperative CT angiography shows significant vascular involvement. After a standard supraorbital incision, I drill the inner table of the frontal bone and the orbital roof. C-shaped roll opening, you can see. As we discussed in previous approach, the first priority, the first target should always be the optic nerve and the carotid artery. But however, in large tumors like this, we can still, in large tumors like this, it's not always possible. But with detailed anatomical knowledge, we can still identify the optic nerve, you can see, and the carotid artery. Not all olfactory groove meningiomas tumors are disentangled with vessels. This case presents a highly challenging surgical scenario. We follow the internal carotid artery and we can see the optic nerve now. After secreting the optic nerve and carotid artery, I remove the tumor in a piecemeal fashion. As you know, this approach provides the shortest route to the anterior skull base. Now, following the carotid artery, I can see the bifurcation M1 and A1 segments. Careful dissection allows me to follow A1 carotid artery. Now we can, I will go back. Now we can see both A1 segments, both A2 segments, communicant segments, and herb artery. And now I open the flux and transition the contralateral side. The 30-degree head rotation allows us to remove the contralateral portion of the tumor through the flux. It seems total excision. Now we will observe the optic nerve meningioma surgery. This patient had previously undergone surgery for a sphenoid wing meningioma. Following the tumor growth in the optic canal, gamma knife treatment was administered and is leading to acute amaurosis. We performed surgery using the supraorbital keyhole approach. However, I aim to use the effect optic nerve from the intact site. Therefore, I choose a contralateral supraorbital keyhole approach. Soon you will understand the rationale behind this approach. After drilling the orbital roof and infrontal bone table, we can see the intact optic nerve and carotid artery. Due to previous surgery and gamma knife treatment, the arachnoid is thick and fibrotic, you can see. Now, the olfactory nerve can be seen here. Yes, we can follow the intact optic nerve to find contralateral optic nerve. The tumor fills the optic canal and it arises, it obscures the nerve borders, you can see. We cannot identify the optic nerve fully. So we open the optic canal and I cut the falciform ligament to mobilize the optic nerve. Then the tumor is removed in small fragments. Once again, we verify the surgical site using an exoscope. Yes, we use an exoscope to verify the surgical fields. The outcome and surgical fit look good. This case involves a highly vascular sphenoid wing meningioma. For these tumors, you can see I used the monkey tail modification of the supraorbital keyhole approach. This technique provides better control of the sylvian fissure. Once again, we perform devascularization and debulking before removing the tumor. Fragment tumor removal is crucial. I remove the tumor piece by piece. For large and highly vascularized tumor, piecemeal removal is essential. Special attention must be given to the vascular structures within the sylvian fissures. So frequent Doppler checks I usually use Doppler to check the vascular permanent. Now I can see the normal brain tissue. I use aspirator, Cusa, and bipolar. Now I can see MCA branches. Retraction should be avoided in this approach. You can see I don't use any retractor for brain. Knowing when to stop is just as important as knowing how to proceed, in my opinion. I use classical meningioma excision techniques, devascularization, debulking, and excision. I control MCA branches. It seems good. You can see I remove the tumor piece by piece. This is a highly vasculated, challenging case for neurosurgeons. But we can operate this kind of tumors due to supraorbital keyhole approach. Most of the tumor has been excised. As I said before, knowing when to stop is just as important as knowing how to proceed. I remove the tumor from the sylvian fissure. We can see internal carotid artery bifurcation, M1 and A1 segments. You know, this is a huge tumor, a giant tumor. You can see the vessels are intact. I often use Doppler to check and to find the localization of the vessels. And it seems good. Postoperative MR seems the excision is successful.
I think the video restarted.
No, this is another video.
Okay.
In this case, I will demonstrate another frontal basal meningioma surgery. After a standard incision, I drill the inner table of the frontal bone and the orbital roof. The draw is opened in a C shape. The cortex is always protected with the surgical and the cotton patties, as you can see. The reason for presenting this case is to highlight a surgical complication. Not everything always goes smoothly in surgery, you know. Following standard tumor devascularization and debulking, the tumor is removed in pieces. Now, let me get the point I want to emphasize in this case. Okay. Despite all precautions, a vascular injury can occur, as seen in this case. Here we observe a transpassing artery. This is an interluminal artery, specified as small frontopolar artery that enters the tumor, supplies the tumor, and then continues its course. During the dissection, the transpassing interluminal artery gets injured by the seizures. Now we can see the injuries, vascular injuries. That's a very small frontopolar feeding artery. What we cut the vessels. Yep. Maybe we can suck feed this small feeding artery. However, this does not match with the principles of minimal invasive microneurosurgery. Minimal invasive microneurosurgery is not just about making smaller incisions, you know. It means maximizing benefit while minimizing harm. As you can see, I place temporary aneurysm clip on the artery. Then I suture it using 10-0 microsutures. Afterward, I check with Doppler to confirm patency. It seems good. However, the tumor is still present. Finally, I proceed with the total tumor resection and conclude the surgery successfully. We can see optic nerve, the carotid artery, the normal brain tissue. After the devascularization, I remove the tumor piece by piece. I remove the tumor, total excision. I perform the excision of tumor, total excision. I find the dissection plane. And now it seems good. Throughout the 6-part journey, I've tried to share my personal experience, Murat and Dr. Bennett, and surgical philosophy. I would like to once again thank Dr. Bennett for providing the opportunity to discuss this case. I also invite every neurosurgeon interested in this field to join our academic and training programs. Thank you, Dr. Bennett.
Thank you very much, Murat.
Dr. Ümit, thank you for these exceptional cases, especially the last one was very inspiring. I want to ask a question. Do you go medially from supraorbital notch or only the
No.
lateral side is enough?
Yes, lateral side is enough. But
Oh.
initially, firstly, I use both supraorbital incision for olfactory groove meningiomas.
Okay.
10
So
years
you
ago.
can use
10 years
both
ago,
eyebrows?
Yes, yes. 10 years ago.
Okay.
Okay. But now I use one supraorbital keyhole.
Of course. Congratulations in these
Thank you.
operations. Truly, this is a value added for Ankara University, and it's a pleasure to be working with you. And I want to thank Dr. John Bennett also to provide us with this opportunity.
Yeah, okay, look, do we have any questions from the panel, Murat? Anybody have it? Now's your chance to ask a famous neurosurgeon some probing questions. Most people a little shy, but that's okay. Okay, very good. Thank you, Amit, for the series. And we really look forward. We hope to do one on robotics when you have a chance. We're going to end. We're going to take a couple of weeks off. And
Yes, we will in touch with you. Yes.
I'm sorry. Go ahead.
Yes, we will in touch with you in soon. Okay.
Great, great. So great. Thanks, everyone.
Dr.
And we'll see you in the next series. Thank you, Doctor.
Thank you.
Thank you. Okay, mute here.